Question 1. A nurse is caring for a client with newly diagnosed idiopathic pulmonary fibrosis. Which assessment finding would the nurse most likely expect to hear upon auscultation of the client's lungs? A. Diminished breath sounds globally. B. Expiratory wheezes. C. Fine, crackling sounds at the lung bases that do not clear with coughing. D. Loud, low-pitched rhonchi that clear with coughing. Answer: C. Fine, crackling sounds at the lung bases that do not clear with coughing. The concept being tested here is the characteristic auscultation finding in idiopathic pulmonary fibrosis, IPF. The keyword idiopathic pulmonary fibrosis points to a restrictive lung disease where lung tissue becomes scarred and thickened. This scarring typically manifests as fine, Velcro-like crackles, rales, heard primarily at the lung bases, which are persistent and do not resolve with coughing because they are due to stiffened alveoli snapping open, not mucus. Diminished breath sounds are general. Expiratory wheezes indicate airway narrowing, like asthma, and rhonchi typically suggest secretions that can clear with coughing, none of which are specific to IPF. For example, imagine crumpled cellophane crackling when you listen to the client's lungs. Remember that crackles associated with pulmonary fibrosis are often described as sounding like Velcro being pulled apart, and they are a hallmark sign of the stiff, fibrotic lung tissue. Question 2. A client with chronic obstructive pulmonary disease, COPD, is admitted with increasing dyspnea and wheezing. The arterial blood gas, ABG, results are pH 7.32, PaCO 258 mm of mercury, PaO 265 mm of mercury, HCO 330 milliequivalent/L. Which acid-base imbalance does this indicate? A. Respiratory acidosis, uncompensated. B. Metabolic alkalosis, compensated. C. Respiratory acidosis, partially compensated. D. Metabolic acidosis, uncompensated. Answer: C. Respiratory acidosis, partially compensated. This question tests your ability to interpret arterial blood gas, ABG, results and identify acid-base imbalances, especially common in respiratory conditions like COPD. The keywords are pH 7.32, which is acidic, indicating acidosis, PaCO 258 mm of mercury, which is high, pointing to a respiratory cause. Normal is 35 to 45 mm of mercury, and HCO 330 milliequivalent/L, which is high, suggesting the kidneys are attempting to compensate. Normal is 22 to 26 milliequivalent/L. Since the pH is still abnormal but the bicarbonate is elevated, the body is trying to correct the respiratory acidosis, making it partially compensated. For example, imagine the lungs are struggling to exhale enough CO2, leading to acid buildup, and the kidneys are working overtime to hold onto bicarbonate to balance it out. Always remember to look at the pH first to determine acidosis or alkalosis, then look at PaCO 2 and HCO 3 to identify the primary cause and compensation status. Question 3. A nurse is assessing a client presenting to the emergency department with an acute asthma exacerbation. Which finding is the most concerning and requires immediate intervention? A. Productive cough with clear sputum. B. Bilateral expiratory wheezing. C. Increased use of accessory muscles for breathing. D. Absence of wheezing with diminished breath sounds. Answer: D. Absence of wheezing with diminished breath sounds. This question tests your understanding of critical assessment findings during an acute asthma exacerbation and the priority of interventions. The most concerning finding, absence of wheezing with diminished breath sounds, indicates severe airway constriction, often referred to as silent chest, where air movement is so minimal that no wheezing can be produced. This signifies impending respiratory failure and requires immediate, aggressive intervention. While expiratory wheezing, productive cough, and accessory muscle use are all signs of asthma exacerbation. The silent chest is a dire warning sign that the client's condition is worsening rapidly, unlike the other options which are typical, though less severe, findings. Think of it this way: if you can't hear the wheezing anymore, it's not because the airways are open, it's because they are almost completely closed, preventing air from moving. Always prioritize the ABCs, and a silent chest indicates a critical compromise of airway and breathing. Question 4. A client with a chest tube inserted for a pneumothorax suddenly develops subcutaneous emphysema around the chest tube insertion site. What is the nurse's priority action? A. Document the finding and continue to monitor the client closely. B. Reinforce the dressing around the chest tube site. C. Notify the healthcare provider immediately. D. Increase the suction applied to the chest tube. Answer: C. Notify the healthcare provider immediately. This question assesses your knowledge of chest tube complications and the appropriate nursing response to a critical finding. Subcutaneous emphysema, indicated by air trapped under the skin causing a crackling sensation upon palpation around a chest tube site, suggests an air leak into the subcutaneous tissue, often due to a dislodged or poorly sealed tube, or persistent air leakage from the lung that the drainage system cannot manage. This finding is significant because it can indicate worsening pneumothorax or a new air leak, potentially leading to respiratory distress, and therefore warrants immediate notification of the healthcare provider for evaluation and potential intervention. Simply documenting or reinforcing the dressing might delay critical treatment, and increasing suction without an order is inappropriate. For example, imagine a tire losing air and bubbling out from around the valve stem. It means the seal is broken or compromised, and needs immediate attention. Always remember that any new or worsening sign of air leakage or respiratory compromise in a client with a chest tube requires prompt communication with the medical team. Question 5. A nurse is caring for a client diagnosed with bacterial pneumonia. Which clinical manifestation would the nurse most likely expect to find? A. Bradypnea and muffled breath sounds. B. Non-productive cough and bilateral fine crackles. C. Fever, chills, productive cough with purulent sputum. D. Hypotension and decreased white blood cell count. Answer: C. Fever, chills, productive cough with purulent sputum. This question focuses on the classic clinical manifestations of bacterial pneumonia. The keywords are bacterial pneumonia, which typically causes an acute inflammatory response in the lungs. Common symptoms include a sudden onset of high fever and chills as the body fights the infection, along with a cough that produces purulent, pus-filled, or rusty-colored sputum due to the inflammatory exudate in the alveoli. Bradypnea, muffled breath sounds, a non-productive cough, and hypotension or decreased white blood cell count are less typical or specific for bacterial pneumonia. For instance, a decreased WBC count might indicate a severe, overwhelming infection, sepsis, or viral etiology rather than a primary bacterial one. For example, think of your body's strong immune response to a bacterial invader in your lungs, leading to these specific and noticeable signs. When you see a question about bacterial pneumonia, picture someone who is acutely ill with a very wet and hot infection. Question 6. A nurse is teaching a client with newly diagnosed chronic bronchitis about managing their condition. Which instruction about breathing techniques is most appropriate to help reduce dyspnea? A. Inhale rapidly through the mouth and exhale slowly through pursed lips. B. Use diaphragmatic breathing, inhaling slowly through the nose and exhaling through pursed lips. C. Take shallow, rapid breaths to prevent air trapping. D. Breathe deeply and hold breath for 3 seconds before exhaling forcefully. Answer: B. Use diaphragmatic breathing, inhaling slowly through the nose and exhaling through pursed lips. This question tests your knowledge of effective breathing techniques for clients with chronic obstructive pulmonary disease, COPD, specifically chronic bronchitis, aimed at reducing dyspnea. Diaphragmatic breathing, belly breathing, helps to strengthen the diaphragm and promote deeper, more efficient ventilation, while pursed lip breathing creates positive pressure in the airways during exhalation, preventing airway collapse and trapping of air, which is a major problem in COPD. Rapid inhalation, shallow breaths, or forceful exhalation can worsen air trapping and dyspnea. For instance, imagine blowing through a straw to slowly deflate a balloon. That's similar to how pursed lip breathing helps expel trapped air and control exhalation. Encourage clients to breathe in slowly through their nose, feeling their abdomen rise, and then exhale slowly through pursed lips, taking at least twice as long to exhale as to inhale. Question 7. A client is admitted to the intensive care unit with acute respiratory distress syndrome, ARDS. The nurse understands that the hallmark sign of ARDS is which of the following? A. Bilateral crackles that clear with coughing. B. Bronchial breath sounds over the periphery. C. Refractory hypoxemia despite increasing oxygen concentrations. D. Hypercapnia with respiratory acidosis. Answer: C. Refractory hypoxemia despite increasing oxygen concentrations. This question focuses on the defining characteristic of acute respiratory distress syndrome, ARDS. The most significant indicator, or hallmark sign, of ARDS is refractory hypoxemia, which means the client's blood oxygen levels remain dangerously low even when they are receiving high concentrations of supplemental oxygen. This happens because ARDS causes widespread inflammation and fluid accumulation in the alveoli, impairing gas exchange and making it extremely difficult for oxygen to diffuse into the bloodstream. Bilateral crackles that clear with coughing typically suggest secretions. Bronchial breath sounds over the periphery are abnormal but not specific to ARDS, and while hypercapnia can occur, the profound, uncorrectable hypoxemia is the primary defining feature. For example, think of the lungs being so stiff and filled with fluid that no matter how much oxygen is delivered, it simply cannot reach the bloodstream efficiently. When you hear ARDS, immediately think hypoxemia that won't get better with oxygen. Question 8. A nurse is caring for a client who recently underwent a total laryngectomy. What is the most critical immediate postoperative nursing intervention to ensure client safety? A. Initiating oral hydration. B. Encouraging verbal communication attempts. C. Maintaining a patent airway. D. Assessing for signs of wound infection. Answer: C. Maintaining a patent airway. This question tests your understanding of immediate postoperative priorities following a total laryngectomy. The most critical intervention immediately after this surgery, which involves removal of the larynx and creation of a permanent stoma, is to maintain a patent airway. Due to swelling, secretions, and the presence of a new tracheostomy, the airway is highly vulnerable to obstruction. While oral hydration, communication attempts, and wound infection assessment are important, they are not the absolute immediate priority over ensuring the client can breathe. For example, imagine a new, narrow pathway for breathing that is prone to blockages. The nurse's first job is to ensure that pathway remains completely open. Always remember that ABCs, airway, breathing, circulation, are the fundamental priorities in any immediate postoperative setting. Question 9. A client is diagnosed with a large pleural effusion. The nurse prepares the client for which procedure to remove the excess fluid from the pleural space? A. Bronchoscopy. B. Thoracentesis. C. Tracheostomy. D. Chest physiotherapy. Answer: B. Thoracentesis. This question asks you to identify the specific procedure used to remove fluid from the pleural space, a common intervention for pleural effusion. A thoracentesis is a medical procedure where a needle is inserted through the chest wall into the pleural space to aspirate, remove, fluid for diagnostic or therapeutic purposes. A bronchoscopy examines the airways, a tracheostomy creates an opening in the trachea for breathing, and chest physiotherapy involves techniques to clear secretions, none of which directly remove fluid from the pleural space. For example, think of the pleural space as a balloon that has filled with water around the lung. A thoracentesis is like puncturing the balloon to drain the water. The key takeaway is to associate pleural effusion, fluid in the pleural space, with thoracentesis, procedure to remove that fluid. Question 10. A nurse is reviewing a client's risk factors for pulmonary embolism. Which finding in the client's history is the highest risk factor for developing a pulmonary embolism? A. History of chronic asthma. B. Recent long-haul airplane flight. C. Current smoking cessation program. D. Daily low-dose aspirin therapy. Answer: B. Recent long-haul airplane flight. This question assesses your knowledge of major risk factors for pulmonary embolism, PE. The most significant risk factor among the choices provided is a recent long-haul airplane flight, because prolonged immobility, such as that experienced during long flights, significantly increases the risk of deep vein thrombosis, DVT, which is the most common cause of PE. DVTs form in the legs during periods of stasis, and a clot can then dislodge and travel to the lungs. While asthma is a respiratory condition, it doesn't directly cause PE. Smoking cessation is positive, and low-dose aspirin is antiplatelet and not typically enough to prevent DVT/PE in high-risk situations. For instance, imagine blood pooling in the legs during a long, cramped flight, making it easier for clots to form. Always think about factors that promote blood stasis when considering PE risk. Question 11. A nurse is performing tracheal suctioning on a client with a tracheostomy. Which action indicates proper technique? A. Applying suction while inserting the catheter. B. Limiting suction passes to a maximum of 3. C. Suctioning for 20 to 30 seconds per pass. D. Hyperoxygenating the client for 30 to 60 seconds before and after suctioning. Answer: D. Hyperoxygenating the client for 30 to 60 seconds before and after suctioning. This question tests your knowledge of safe and effective tracheal suctioning technique. The correct and most important action for client safety is hyperoxygenating the client for 30 to 60 seconds before and after suctioning. This crucial step helps prevent hypoxemia, low oxygen levels, during the procedure, as suctioning removes not only secretions but also oxygen from the airway. Applying suction during insertion can damage the mucosa. Suctioning should be limited to a maximum of 10 to 15 seconds per pass, not 20 to 30, and generally, no more than 2 to 3 passes are recommended to minimize trauma and hypoxemia. For example, think of preparing the client's lungs for a brief period of low oxygen by providing extra oxygen reserves beforehand. Always prioritize patient oxygenation when performing any airway intervention. Question 12. A client with chronic respiratory failure is prescribed BiPAP, bilevel positive airway pressure, at night. The nurse understands that the primary goal of BiPAP is to A. Deliver a continuous fixed pressure to keep airways open. B. Provide both inspiratory and expiratory positive airway pressure to improve ventilation. C. Completely replace spontaneous breathing. D. Administer high-flow oxygen without positive pressure. Answer: B. Provide both inspiratory and expiratory positive airway pressure to improve ventilation. This question examines your understanding of BiPAP therapy. The core function of BiPAP, bilevel positive airway pressure, is to provide both inspiratory and expiratory positive airway pressure to improve ventilation. This means it delivers a higher pressure during inhalation, IPAP, to help open the airways and assist with breathing in, and a lower pressure during exhalation, EPAP, to keep the airways from collapsing and improve gas exchange. CPAP, continuous positive airway pressure, delivers a single, continuous pressure, while BiPAP does not completely replace spontaneous breathing but rather supports it, and high-flow oxygen does not necessarily provide positive pressure. For example, imagine BiPAP giving your lungs an extra push when you breathe in and helping them stay open when you breathe out. Remember that BiPAP is about providing two distinct pressure levels to help with both inspiration and expiration, making it effective for improving ventilation and reducing the work of breathing. Question 13. A client with a stab wound to the chest suddenly becomes severely dyspneic, cyanotic, and tracheal deviation to the unaffected side is noted. The nurse suspects a tension pneumothorax. What is the nurse's immediate priority action? A. Prepare for chest tube insertion. B. Administer a high concentration of oxygen via non-rebreather mask. C. Call for a rapid response team and prepare for needle decompression. D. Auscultate lung sounds and obtain a stat chest X-ray. Answer: C. Call for a rapid response team and prepare for needle decompression. This question presents a classic scenario of a life-threatening tension pneumothorax and asks for the immediate priority action. The keywords are stab wound, severely dyspneic, cyanotic, and crucially, tracheal deviation to the unaffected side, which are all hallmarks of a tension pneumothorax, a medical emergency where air accumulates in the pleural space and shifts mediastinal structures, compressing the unaffected lung and heart. The immediate priority is to relieve the pressure, which is done through needle decompression before a formal chest tube can be inserted. While oxygen is needed, and a chest X-ray will confirm, these will not immediately relieve the pressure. For instance, imagine a rapidly inflating balloon inside the client's chest, squeezing everything vital. The immediate need is to pop that balloon to release the pressure. Remember that needle decompression is a life-saving intervention for tension pneumothorax, and rapid response activation is key. Question 14. During a respiratory assessment, the nurse hears loud, bubbling, moist sounds that are more prominent on inspiration and do not clear with coughing. How should the nurse document these breath sounds? A. Wheezes. B. Rhonchi. C. Fine crackles. D. Coarse crackles. Answer: D. Coarse crackles. This question tests your ability to differentiate various adventitious breath sounds. The description of loud, bubbling, moist sounds that are more prominent on inspiration and do not clear with coughing points directly to coarse crackles, formerly called rales. These sounds are typically heard when air passes through airways containing secretions or fluid, often indicating conditions like pulmonary edema or pneumonia. Wheezes are high-pitched musical sounds, rhonchi are low-pitched snoring sounds that often clear with coughing, and fine crackles are brief, high-pitched, and non-clearing. For example, imagine a gurgling sound in a drain pipe, that's similar to coarse crackles. Always distinguish between sounds that clear with coughing, secretions, like rhonchi, and those that don't, fluid or structural issues, like crackles. Question 15. A client with severe hypoxemia is prescribed oxygen therapy at 6 liters per minute via nasal cannula. What is the most important safety consideration for the nurse to implement? A. Ensure the client eats a low-sodium diet. B. Monitor for signs of carbon dioxide narcosis. C. Instruct the client to avoid cotton clothing. D. Place no smoking signs prominently. Answer: D. Place no smoking signs prominently. This question emphasizes a critical safety consideration for clients receiving oxygen therapy. Oxygen, even at relatively low flows, is a highly combustible gas and supports combustion. Therefore, the most important safety measure is to place no smoking signs prominently to prevent fires, especially when oxygen is being administered in the home or an environment where smoking might occur. While monitoring for CO2 narcosis is important for clients with COPD, and cotton clothing is generally safe, fire safety is paramount with oxygen. A low-sodium diet is unrelated to oxygen therapy. For example, think of oxygen as fuel for a fire. You must eliminate all ignition sources. Always prioritize fire safety when oxygen is in use, whether in a hospital or home setting. Question 16. A nurse is instructing a client on the correct use of an incentive spirometer. Which statement by the client indicates a need for further teaching? A. I should breathe in slowly and deeply through the mouthpiece. B. I should try to get the indicator to reach the goal mark. C. I need to cough deeply after using the spirometer. D. I should exhale into the mouthpiece as forcefully as possible. Answer: D. I should exhale into the mouthpiece as forcefully as possible. This question tests your understanding of the correct technique for using an incentive spirometer. The purpose of an incentive spirometer is to encourage slow, deep inspiration, breathing in, to expand the lungs and prevent atelectasis, lung collapse. The statement, I should exhale into the mouthpiece as forcefully as possible, indicates a misunderstanding, as the device is designed for inhalation, not exhalation. Proper use involves slow, deep inhalation to raise the indicator, holding the breath for a few seconds, and then exhaling slowly. Coughing deeply afterward is indeed beneficial for clearing secretions. For example, imagine trying to suck liquid up a straw, which requires a sustained inward breath, not a forceful outward breath. Always emphasize the inspire part of incentive spirometry to your clients. Question 17. A client with a history of asthma arrives in the emergency department reporting severe shortness of breath, wheezing, and is unable to speak in full sentences. The nurse notes the client is agitated and diaphoretic. The nurse recognizes these signs as indicative of A. Bronchitis, B. Status asthmaticus, C. Pneumonia, D. Allergic reaction. Answer: B. Status asthmaticus. This question describes the hallmark presentation of status asthmaticus, a severe and prolonged asthma attack that does not respond to standard bronchodilator therapy and is a medical emergency. The key phrases are severe shortness of breath, unable to speak in full sentences, agitated, and diaphoretic, all pointing to extreme respiratory distress and impending respiratory failure, beyond a typical asthma exacerbation. Bronchitis is inflammation of the bronchi, pneumonia is lung infection, and an allergic reaction could cause similar symptoms, but the context of asthma history and severity points specifically to status asthmaticus. For example, think of it as an asthma attack that has gone from bad to critical, where the client is clearly fighting for air and is on the verge of respiratory collapse. Recognize that a client who cannot speak in full sentences due to dyspnea is in severe respiratory distress. Question 18. A newly admitted client has a positive PPD, purified protein derivative, test and symptoms suggestive of active tuberculosis, TB. What is the priority nursing action regarding infection control? A. Place the client in a private room with contact precautions. B. Administer prophylactic antibiotics immediately. C. Place the client in an airborne infection isolation room. D. Encourage visitors to wear surgical masks. Answer: C. Place the client in an airborne infection isolation room. This question focuses on the essential infection control measures for suspected or confirmed active tuberculosis, TB. TB is primarily transmitted via airborne droplets, making airborne infection isolation room, often called a negative pressure room, the priority for infection control. This type of room ensures that air flows into the room and then is exhausted to the outside, preventing airborne pathogens from escaping into the hallway. Contact precautions are for direct or indirect contact, not airborne. Prophylactic antibiotics are not a nursing decision or an immediate infection control measure, and encouraging visitors to wear surgical masks is insufficient for airborne transmission, though visitors should wear N95 respirators. For example, imagine tiny invisible particles of the bacteria floating in the air. You need a special ventilation system to contain them. Remember that TB requires airborne precautions, including an N95 respirator for healthcare workers. Question 19. A client is recovering from a right lower lobectomy for lung cancer. The nurse observes continuous bubbling in the water seal chamber of the chest tube drainage system. What is the most appropriate initial nursing action? A. Document the finding as normal post-lobectomy. B. Check all connections from the client to the drainage system. C. Increase the suction setting on the chest tube drainage system. D. Clamp the chest tube to assess the source of the leak. Answer: B. Check all connections from the client to the drainage system. This question addresses a common issue with chest tube management: continuous bubbling in the water seal chamber. While intermittent bubbling with respiration, tidling, is normal, continuous bubbling in the water seal chamber indicates a persistent air leak. The most appropriate initial nursing action is to check all connections from the client to the drainage system because external air leaks at connections are the most common and easiest source of a leak to identify and correct. Documenting it as normal is incorrect. Increasing suction might worsen the leak or not address the cause. Clamping the chest tube is generally avoided as it can lead to a tension pneumothorax if the air leak is from the client's lung and air cannot escape. For example, imagine a garden hose with a tiny hole. You check the hose and its connections first before assuming the water source is the problem. Always systematically troubleshoot from the client connection outward when you suspect a chest tube air leak. Question 20. A client with a new tracheostomy is unable to speak. The nurse understands this is due to A. Swelling around the vocal cords that resolves quickly. B. The tracheostomy tube bypassing the vocal cords. C. Sedation causing decreased level of consciousness. D. Damage to the recurrent laryngeal nerve during surgery. Answer: B. The tracheostomy tube bypassing the vocal cords. This question tests your fundamental understanding of how a tracheostomy impacts speech. A tracheostomy tube bypasses the vocal cords because it is inserted below the larynx, voice box, where the vocal cords are located. Air no longer flows over the vocal cords, which are essential for producing sound. While swelling, sedation, or nerve damage could affect speech in other contexts, the primary and expected reason for aphonia, inability to speak, with a tracheostomy is the redirection of airflow. For instance, think of the vocal cords as guitar strings. If air doesn't vibrate past them, no sound can be made. Remember that clients with a tracheostomy will need alternative communication methods unless a speaking valve is used, which directs air back over the vocal cords. Question 21. A nurse is educating a client newly diagnosed with asthma about their prescribed medications. The nurse explains that Albuterol is a rescue medication because it A. Reduces airway inflammation over time. B. Provides rapid, short-term bronchodilation. C. Prevents asthma attacks when taken daily. D. Thins respiratory secretions to improve breathing. Answer: B. Provides rapid, short-term bronchodilation. This question focuses on the primary role of albuterol in asthma management. Albuterol is a short-acting beta-2 agonist, SABA, and is considered a rescue medication because it provides rapid, short-term bronchodilation. It works quickly to relax the smooth muscles around the airways, opening them up to relieve acute symptoms like wheezing and shortness of breath during an asthma attack. Medications that reduce inflammation, like corticosteroids, or prevent attacks, like long-acting beta-2 agonists or inhaled corticosteroids, have a different, long-term purpose, and albuterol does not primarily thin secretions. For example, think of albuterol as a rapid-acting fire extinguisher for an acute asthma flare-up. Always associate albuterol with quick relief and bronchodilation. Question 22. A 25-year-old client with cystic fibrosis, CF, is admitted with increased sputum production and coughing. The nurse anticipates an order for which intervention to help clear the client's airways? A. Fluid restriction. B. High-flow oxygen via nasal cannula. C. Chest physiotherapy. D. Broad-spectrum antibiotics only. Answer: C. Chest physiotherapy. This question targets the primary non-pharmacological intervention for airway clearance in cystic fibrosis, CF. Clients with CF produce thick, tenacious mucus that can obstruct airways, leading to recurrent infections and lung damage. Chest physiotherapy, CPT, which includes techniques like percussion and vibration, is a crucial intervention to mobilize these thick secretions from the lungs, allowing them to be coughed up. While antibiotics are often needed for infections, fluid restriction would worsen mucus viscosity, and high-flow oxygen might be used for hypoxemia but doesn't clear secretions directly. For example, imagine trying to loosen very sticky glue from the inside of a tube. You'd need physical force like shaking or tapping, similar to CPT for mucus. Emphasize that CPT is a cornerstone of CF management to maintain airway patency. Question 23. A nurse is reviewing the pulmonary function test, PFT, results of a client with emphysema. Which finding is most consistent with this diagnosis? A. Increased forced vital capacity, FVC. B. Increased residual volume, RV. C. Decreased total lung capacity, TLC. D. Normal forced expiratory volume in 1 second, FEV1. Answer: B. Increased residual volume, RV. This question assesses your understanding of pulmonary function test, PFT, abnormalities in clients with emphysema, a type of COPD. Emphysema is characterized by the destruction of alveolar walls, leading to enlarged air spaces and air trapping. This air trapping results in an increased residual volume, RV, which is the amount of air remaining in the lungs after a maximal exhalation. Other findings typically include a decreased FEV1, forced expiratory volume in 1 second, and a normal or increased total lung capacity, TLC, not decreased. An increased FVC is not characteristic. For example, think of the lungs losing their elasticity, becoming like overstretched balloons that cannot fully deflate, leaving more air trapped inside. Always remember that air trapping is a hallmark of obstructive lung diseases like emphysema, which directly leads to an increased residual volume. Question 24. A client underwent a bronchoscopy procedure earlier today. Which of the following post-procedure findings requires immediate notification of the healthcare provider? A. Sore throat and hoarseness. B. Absent gag reflex. C. Bronchospasm and stridor. D. Blood-tinged sputum. Answer: C. Bronchospasm and stridor. This question focuses on identifying critical complications following a bronchoscopy. While a sore throat, hoarseness, and blood-tinged sputum are common and usually benign post-procedure findings, and an absent gag reflex is expected until local anesthesia wears off, bronchospasm and stridor indicate acute airway obstruction and a potentially life-threatening complication. Stridor is a high-pitched, whistling sound caused by turbulent airflow through a narrowed upper airway, often due to laryngospasm or edema, requiring immediate intervention. For example, imagine the airway suddenly clamping down, making it extremely difficult to breathe, which is what bronchospasm with stridor signifies. Always prioritize signs of airway compromise after any procedure involving the respiratory tract. Question 25. A client with severe respiratory distress is experiencing hypercapnia. Which clinical manifestation would the nurse most likely observe? A. Kussmaul respirations. B. peripheral cyanosis. C. Bradypnea with decreased depth. D. Somnolence and headache. Answer: D. Somnolence and headache. This question tests your knowledge of the clinical manifestations of hypercapnia, which is an elevated carbon dioxide level in the blood. Carbon dioxide acts as a vasodilator and can have narcotic effects on the brain. Early signs of hypercapnia often include headache, due to cerebral vasodilation, and somnolence, drowsiness or decreased level of consciousness, progressing to confusion and coma as CO2 levels rise further. Kussmaul respirations are deep, rapid breaths associated with metabolic acidosis. Peripheral cyanosis indicates poor peripheral perfusion and hypoxemia. Bradypnea with decreased depth would worsen hypercapnia, not be a direct symptom of its effects on the brain. For example, imagine CO2 building up like a sedative in the brain, making the client feel sleepy and confused. Always remember that neurological changes, such as drowsiness and headache, are key indicators of rising carbon dioxide levels.